I'm just saying I'm not finished yet. Search for it, swing for it, discover the me that lives in yes. Stand for it, stretch for it. It's my time, imagine my best. Run for it, reach for it, uncover the me that lives in yes. I know, yes I know, there'll be miracles wherever I go. It's not work, it's play. I can make magic today.
Hi, everyone. Welcome to Senior Nation. I'm your host, Phyllis Ayman, and you are listening to the Source TV radio network, WTSN, Washington, D.C. We are indeed a senior nation with 100 plus million adults over the age of 50. And we are here to bring you up-to-date information about successful aging, healthful longevity, and becoming what I call a well-ager. To dignity, respect, quality of life, and quality of care for our parents, our grandparents, and loved ones. We at Senior Nation will be your trusted voice for informed choices, meaningful conversations, and a vibrant life at every age. Though the Source TV radio network, it's known for its dedication to bringing the highest level of jazz content to the viewing and listening audience, the owners of the network are also dedicated to bringing this important content to this fast-growing demographic. And I'm very grateful to have this opportunity. So let's begin with tonight's show. My guest tonight is Ruth Bier, who has had a long career as a nurse, nurse educator, and co-founder and 35-year president of PCH Home Care Agency. The story of how the agency came about with a bridge table and 2 chairs in Yonkers, New York is not only compelling, but a testament to recognizing a problem in need of a solution. The breadth of Ruth's knowledge and experience is invaluable for anyone needing or considering home care for themselves, a parent, or a loved one. We will discuss the difficult decision-making process and difficult conversations when choosing home care, as well as address when home care may no longer be viable. So let's begin with tonight's show.
Good evening. I'm Ruth Bier. I'm an RN, and I've gotten my bachelor's and my 60 credit master's from Columbia, and I finished my coursework towards my doctorate. I got into the home care business because, believe it or not, I had been teaching for 8 years at Bronx Community College. And during the A-Beam administration, I was not rehired because they were looking for a more diversified faculty. I think that was probably the best thing that ever happened to me, because I then got into home care.
You know, I just want to interject something there. You know, I love what you said, because sometimes, you know, when they say when one door closes, another one opens, and you don't even recognize what the opportunity is sometimes until later on down the road. So I'm really interested in how this kitchen table and 2 chairs in Yonkers helped start this whole agency.
I joined with a partner, female, who was not a nurse, but was looking to work. She had been in retail and her store closed. And the 2 of us got together and said, what can we do? We wanted to work. And we came up with home care. We chose Yonkers because we were able to get a small space across from a major hospital in Yonkers, and we felt that we would get the referrals from that source to start our business off.
So really, so from what I'm gleaning from what you're saying, it was just because you were two people who were looking for like the next endeavor, right? The next pursuit.
Absolutely.
That's terrific.
Absolutely. So we leased this small space, and with a bridge table, 2 chairs, and 2 phones, 2 telephones, and we decided to start home care. And the way we started was I went to the hospitals that knew me because I had been teaching, and I gave them a card, a business card, and I said, we are accepting all referrals now. And it caught on because we were competing with what we're going to call the major companies like Upjohn, Quality Care, just a lot of very big agencies that just, for example, did not answer the phone after 5 o'clock. And we stayed, we were on call. If someone called and needed us, they got a live person on the phone. And that's how we got started.
So I have a question, because
Yes.
35 years ago, home care certainly wasn't as popular as it is today. And we'll get into that discussion a little later. So did you find challenges because of that? Because there weren't so many people looking at home care as a solution then?
The biggest challenge is we had to get ourselves licensed. You cannot just open an agency and say, well, now I'm doing home care.
Right.
So we submitted the paperwork, and we did get licensed. And then we realized that there were either private pay or Medicaid. And the larger population, unfortunately, at that time were Medicaid patients. So we submitted a price to do our service, and we lowballed everybody else.
Right.
We got a Medicaid contract with the state of New York.
Oh, cool.
It was fabulous. Okay.
Right.
First of all, we had very little overhead. We were sitting in a very small office, but we had to meet payroll, and that was very challenging.
I can imagine.
Certainly, we were under. We certainly didn't have sufficient funds when we first opened up, and we were trying to do it on our own. So we had the experience of going to a major bank, and we were 2 women, and it was 1980.
Right.
They kind of laughed at us,
Right.
and they were not giving us any money. So we did go to our husbands for some help, and that's how we got started.
So let me ask you a question also. So at that time, 35 years ago, there's certainly, you can answer this question, obviously. I can imagine there weren't people clamoring to do home care. So how did you recruit caregivers for the patients that you were getting? Like, which grew more rapidly?
Well, number 1, we advertised. Number 2, the people that we hired, because we became licensed, had to go through a training program. So we went to all the training programs in the Bronx, Brooklyn, Yonkers, etc. And we recruited from those training programs because these were people that needed to work, and they took the course, they passed it, and then they came to work. So that's what we did. And little by little, we built up our staff.
Right.
We became, over a period of time, the largest Medicaid provider in New York,
Wow.
simply because we did our work, and we
Right.
did it honestly.
Right. Huh.
And we had standards. We had a nurse who went out to make assessments, even though we did not get paid for that. Through Medicaid, we sent out an RN. So at the beginning, I was the RN. So I went out and, made an assessment and decided how many hours of care the patient would require. And then we had to have it approved by Medicaid.
Right. So I have another question. Sorry. I have another question.
Sure.
Because I'm thinking of questions that listeners or viewers may want the answers to, and somebody might, write in with their own question. Did you see, so you said you had this agency for 35 years, correct?
Yes.
So how during those 35 years, did you see a change in the severity of the patients that you were getting who needed home care, or a change in their conditions?
Well, let me put it this way. We entered the real world, and it's very cutthroat, like any other business. So
Right.
we realized not only did we have to be licensed, but we had to be certified. And a certified agency can care for Medicare patients. A licensed agency cannot. So we became Medicare certified and licensed. Now, we were Medicare certified in Connecticut, but not in New York. In New York, they were only allowing not-for-profit agencies to be certified. So a word to the wise. Let me just, because people are going to ask this. If the person is 65 or over and has Medicare, they are entitled to home care. Not much,
Right.
but they are entitled to a few hours.
Right.
And they should absolutely take advantage of it.
Right.
And then afterwards, the family can determine, can this person remain safely in their home? That's the main thing, that the patient must be safe.
Right.
And, if they are not safe, then they have to either go privately, or they have to go to a religious agency that may be able to provide some care free of charge.
Or, as you and I have discussed many times, sometimes people have to move into an alternative setting, but right now we want to concentrate on home care.
Home care.
So just getting back to that, my question, in the period of the 35 years, did you see a change in the severity or the kinds of conditions that people had who needed care at home?
Well, firstly, 35 years ago, people were not living as long as they are now. So the lifespan was shorter 35 years ago. So we would have what we would now consider younger patients that required care. Unfortunately, it might be a behavioral issue, which we had a department for, and or it could be someone, for example, that has osteomyelitis and requires IV therapy.
Can
So
you excuse me, can you just tell people what osteomyelitis is if they don't know?
It's an inflammation of a major bone in the body.
Okay.
And it can lead to sepsis. So it's very important that it be treated with IV therapy. So in other words, as the years went on, we developed IV therapy. That would be one place. Number two, behavioral health. That would be a second. And third would be just hands-on care for people who cannot take care of themselves for whatever the reason may be. I am an advocate of home care.
Yeah, me too.
Whenever possible.
Right.
Keeping the patient at home safely is the way to go.
No, I agree. And nowadays, you know, there are so many stories and examples, and I think it came to light more during COVID, although people knew about this beforehand, but COVID really brought it into the light, I'll say, about the failures, I'll call it, of the long-term care nursing home system, which I come from. And so I certainly am a huge advocate of people staying at home as long as they can. However, I am going to ask you this question, which is, in my experience in the last several years, and this is very unfortunate, and I kind of think I know the answer you'd give, but based on my experience, I approached many home care agencies, more than hundreds, and I knew owners of several of them, and I approached them about doing specialized training because I think, which is kind of where I was headed with my question, are there more people at home that have cognitive impairment, dementia, Alzheimer's disease, and maybe have had strokes and have other difficulties. And so I had approached many home care agencies about doing specialized training from my particular area of expertise. I'm a dementia care specialist and a swallowing, I specialize in swallowing difficulties. And as people advance in years, they have difficulties in those areas as well as memory issues. And I could not get one agency, whether I was willing to provide it at no charge or a small charge. Several of them had schools who were willing to engage my services to provide their caregivers with specialized training so they can meet the needs of people who have more advanced difficulties in those areas.
Well, we happen to have done quite a bit of that because behavioral health encompasses a large, there's just a lot of definitions of behavioral health.
Right.
And certainly Alzheimer's or dementia or even Parkinson's develops into a decrease in cognitive skills. So the answer is yes. The question is always, what is the payer source? That is the main issue, because for us to train people in an area, we needed let's say, at least 8 to 10 people in the class. The instructor had to get paid. And where was this money coming from? It had to come from the owners of the agency. And the people that you train do not necessarily stay with you. It's a very, these aides really go from one agency to the next. So that if I'm paying $20 an hour, they may find an agency that's paying $22. So you can train them. They don't necessarily remain with you. And that is a realistic problem.
I've heard that.
for an agency that's a for-profit
Uh,
agency.
I've heard that. Yep. I've heard people say that. Of course, so from my vantage point, as a practitioner who wants to see people get care at the highest possible level, if I had a loved one of the questions that I'd be asking an agency is what kind of training is the caregiver going to have who's going to be caring for my loved one who may have a particular set of symptoms associated with a condition, whether it's Parkinson's or Alzheimer's or MS or whatever it is.
Okay. Those kind of questions are, correct. Yeah, they're appropriate. The thing is that only a private pay family would interview an aide. Okay? That's the reality.
Interesting.
If you're going to pay out of pocket, you want to be sure of who is coming into your home and whether or not they have the experience that you feel your loved one needs. On the other hand, if you are a Medicaid patient where the government is paying for your service, you don't really have that opportunity to do that. That's a reality.
I didn't know that. I just learned something myself.
Yes. So, I want to really go into it more because there are licensed agencies, certified agencies, and then there are registries. And a registry is just someone who sets up shop, hires people that they've heard about or that have been referred to them, and the money is collected by the aide. So the aide goes into the home, and this is what she charges the family. And then it is her obligation to pay a percentage of that back to the agency.
Oh, okay.
Now, a registry person does not have the kind of coverage that someone that works for me would have. So let me give you an example.
Yeah.
Someone calls and says, I'm taking my mom to Florida. I would like to take her aide with me. Okay? Now, if I'm not licensed in Florida, she takes her at her own risk.
Oh.
I'm saying that because the number of accidents that happen once you remove a patient from their environment is unbelievable. So the accidents happen to the aide. She'll say, I picked the patient up. She was very heavy and I couldn't transfer her. All right. Now she's not working for me. She's working on her own for the family. And now she starts with a disability issue. The disability will be paid for by the family and not the agency.
Interesting. Okay.
So the advantage of using a licensed or a certified agency is tremendous. It's a reality. If the aide hurts herself on the job or the patient says, the aide did something that hurt my mom, okay, we are responsible. We stand behind the aide and the patient. And that is not so with the registry. So I'm for licensed and or certified, depending on the payer source.
Okay.
Now, there are many patients who say, I'm going to hire someone on my own.
Right.
I don't want to be busy paying an agency. Why should I pay an agency fee? Okay. And you know, this is very common.
Right.
So,
Absolutely.
number one, without getting into politics, they sometimes hire people that are not here legally. That's number one. If a licensed agency does that, we are fined $10,000 a day
Oh, wow.
for employing a someone who is not here legally.
Okay.
So that's one issue that comes up. The second issue is you really don't know anything about this person that walks into your house. Someone that we send, we have references for, we've checked them, we've seen what they can or cannot do, we know their strengths and weaknesses. If you hire someone on your own, you're hiring a stranger to come into your home.
A question: does an agency do background checks? And also, if a person or family wanted to hire somebody privately, could they also do a background check?
That's a complicated question. So, for example, our agency, the aide had to sign something that said that they would not work for the family unless it was through us.
Okay, that's like a non-compete.
Well, no, that's saying that if the family says, you know, I really like this aide, why don't you work for me? You don't have to work for the agency, work for me. Okay. And they pay them off the books, so to speak. Everyone that worked for me got a paycheck. And
Okay.
they had all the deductions.
Okay, but wait, I just want to go back to that question. Did your agency do background checks? And if a person wanted to hire somebody on their own, could they also do a background check to make sure that this person was who they said they were and didn't have any, criminality in their background?
Well, what we did on a routine basis was we did criminal checks.
Okay. That's what I wanted to know.
Yes. Now, can someone privately do it? I can't answer that. I really don't know.
Okay.
But we did do criminal checks. Now, does that work all the time? The answer is no.
Right.
But we tried our very best. And very honestly, in all the years that we were in business, and I had 9 offices, so I was in 3 states, and I had to comply with the different regulations in each state. I can honestly say I never, ever had a major liability suit against personalized home care.
Oh, that's tremendous.
And it's because we kept on top of it. Even though we employed a lot of people, we sent out over 3,000 W-2s at the end of the year. We had sufficient supervision in each office. So we really ran, it was straight and narrow. If you got somebody from personalized home care, you knew they weren't going to walk out with the silver in the drawer.
Right. So I have a question. So which 3 states were you in? New York,
New Jersey, and Connecticut.
Okay. So you were really in the tri-state area.
Yes, we were.
That's really terrific. So I would assume that, there are many other states across the country that each state has their own rules and regulations for compliance for home care agencies.
Yes. The answer is yes, they do.
And so how would wait, I just have a question about, sorry, I have a follow-up question. How would people, if they have a need, let's say they live in Wyoming or Illinois, wherever it is, how would they find out what the rules and regulations were for compliance for a home care agency in their state?
You mean if someone wanted to start an agency?
No, if they had a loved one who needed care and they wanted to know about the standards for home care agencies in their state, is there a way to find out about that?
It can right now you get everything through Google.
Right.
So I'm assuming that that's what one would do. I mean, it's really difficult to get yourself started. And it is very different in each state, unbelievably so.
Right.
So I just want to say something about the advantage of a patient remaining home rather than in a facility. So right now, with the regulations being what they are, they keep a patient in the hospital for a very short time, maybe too short.
Correct.
The reason being that the hospitals are not being paid well. So they discharge the patient. The first thing they do is they are discharged to rehab. Everyone now, I hardly know anyone that is discharged that doesn't go to rehab.
Very few and far between. There are some, but very few and far between. But I just want to, somebody just asked a question, so I just want to make sure we address this. Dolores says, what is the minimum requirement for training for one of your home nurses, an LPN or an RN?
Well, we don't train LPNs or RNs. They come to us with their certificate that they have already become an RN. And the same thing would be true for an LPN. So they've already been through their program. The training that we did was for the home health aides. And we actually did it. We didn't start doing it this way, but as we grew, we started training them in our office. We had one room that was designated for training. And we had RNs that trained these people and then observed them in the clinical area.
Okay, so she had a follow-up question, a follow-up comment, which was, that's not my question. What is your minimum? So what you're saying is your minimum was that they came with their certifications as an LPN or an RN. That was a basic, right?
Yes.
Okay. I hope that answers the question.
Well, I just want to say that we hired very few LPNs because they just weren't as well trained as the RN is. And so we hired very few LPNs, but they came with a certificate. They had already graduated.
Right. Did they have to have a certain amount of experience before you hired them? Because obviously there's a very big difference for somebody in any profession who's right out of school, versus somebody who has had experience.
Quite honestly, very few new graduates go into home care. They don't. They go into a clinical setting so that they get the experience of caring for the very ill. But we would not hire someone who was just out of school and had not been out in the field. They would have to have some kind of experience, behind them, because they're alone with the patient. They have a lot of decisions that have to be made, and that many times they're doing it on their own. So
Right.
they have to be very well qualified. And
Right.
that's a major thing. It really is. It's just a major thing.
So that would be, I would say, an important question for somebody to have if they're looking for care for their loved one at home, and if they, they are going to have an RN interact with their loved one at some point, depending on what the medical situation is, because there are some situations that only an RN can address as opposed to a certified nurse aide. There are certain a scope of practice that is acceptable for a CNA, a certified nurse aide, as opposed to an RN. So that might be a good question for someone to ask of an agency.
Well, the likelihood is for home care, people do not hire an RN, 24 hours a day.
Right.
In other words, the RN would be there really to come in and either supervise the aide, teach her what has to be done. For example, if the patient had a colostomy, she would see how the aide is doing it. If there were medications that had to be poured, the RN would be there to do that. But she's usually not hired to actually care for the patient over a period of time.
No, I understand that, but the question might still be, if an RN is going to visit my loved one's home, how much experience did they have in the field before they're employed by your agency, not yours, but any agency anywhere? That's what I meant.
Well, for me, I would look at the experience they had when they graduated. I mean, that's the big thing. Have they dealt with critically ill patients?
Right.
That kind of thing. And what we had was a checklist. Have you done this? And it's a checklist of, let's say, I think there were 20 items on it, and the RN would check off, I've done this, I haven't done this, that kind of thing. So that when they were making a visit to a patient that had a particular illness, we would know whether or not this nurse can handle that situation. So,
well, that's good to know. That's probably good for people to ask. Another question I have is, because obviously I'm somewhat familiar, not somewhat, I am very familiar. There are things that a CNA who is going to be with the person, and let's say it's a protracted number of hours a day, let's say it's 6 hours, let's say it's 8 hours. There are certain things a CNA, whether somebody comes in and watches them do it or not, that is not in their scope of practice. As opposed to an RN, let's say like an IV or, there are certain things that
they would not be doing it.
Okay, right. Okay. But that's something that people, I would think, should be aware of if their loved one or needs an injection of insulin or whatever it is. There are certain things that are not in the scope of practice for a certified nurse.
Well, let's use that example.
Okay, good.
Insulin. Okay. That we have a lot of diabetics at the present time.
Correct.
So what we do is, number one, before the patient is discharged, if they're coming from a hospital to home, someone in the family needs to know how to inject that insulin. One person.
Right.
Now the patient goes home. The RN goes in and supervises the person giving the insulin. There are very few times when the aide would be giving insulin unless she was really supervised very closely by the RN.
Okay. Now,
not only are you giving insulin, but you're also looking for the side effects.
Right. Right.
Is the patient hypoglycemic, hyperglycemic? And these are observations that would be made by a professional, rather than by an aide.
Right. So then Selena says, I'm an RN. There are different types of RNs, which you and I both know, and many RNs specialize in various areas of healthcare, such as critical care, oncology, emergency rooms, or labor and delivery. Additionally, some RNs pursue advanced practice roles like nurse practitioners, true, or clinical nurse specialists. Are you matching patients with specific RNs based on their infirmity?
The answer, let me just answer that because it's certainly easy enough. When an RN picks a field that she is particularly interested in, let's say oncology or some other field, she would be working for an agency just in that area. In other words, that would be her specialty. So that if she had to hang an IV with something in it, a chemotherapeutic agent, she would be the one that would be doing that, rather than an RN who specializes in something else, some other field.
Labor and delivery, let's say.
Yeah, labor and delivery. Well,
Right.
a labor and delivery nurse would most probably not be in home care.
Right.
But yes, we always try to do that. And we've done it with IV therapy. We've done it with ostomy care, these specialties. And we definitely try to get an RN who is comfortable with doing that, rather than taking someone who is not. It's very, let me just say this, it's very difficult to recruit RNs, because they tend to either want to be affiliated with a hospital, or they want to be able to open up an office and hang a shingle for themselves. It's one of the things that I love about nursing. And they don't really tend to go into home care. They will do it. They'll give an agency, let's say 10 hours a week, to make extra money. But that's the reality of the field.
Right. Well, Selena was very happy that we answered the question she was asking. So I'm glad we were able to do that. So, you and I have talked about this also. And what about hospice? What about when a person is approaching end of life for a variety of reasons, whether it doesn't matter, whatever the reason is, whether it's cancer, Alzheimer's, whatever, what about when people have to transition to hospice? Can you talk about that a little bit?
Yes,
Hospice
I can.
meaning end of life.
Yes, I can. So hospice has very special needs, and hospice care can be given either in the home or in a facility. Now, in order for us to, a licensed agency, to undertake a hospice patient, we would have to have a contract with a hospice organization. So it's very separate. And the same thing with palliative care. It can be given in the home or in a facility. But it's given because the payer source is different for hospice and palliative care.
Can you just describe or differentiate for viewers and listeners the difference between palliative and hospice?
Yes. Hospice care the family has decided not to provide any medical treatment for the patient. They are basically keeping them alive with fluids if that is the family's wish. And that must be designated in the healthcare proxy. I am very strong on patients having healthcare proxies. Palliative care is, you know, you're not going to cure the illness, but you are still treating the patient.
Right.
So that if the patient's hemoglobin is very low and is therefore having difficulty breathing, and they're on a palliative unit, they will receive blood.
Right.
So there's some active treatment with palliative, and hospice care there really is not.
So
Hospice
palliative,
care has its place in our society.
I agree. Sometimes we use the word palliative synonymous, well, interchangeably with comfort care. You are still providing treatment and the person is comfortable. Whatever, hospice is really kind of more like end of life. Would you say?
Yes. But it has to be the wish of the family and the patient. And that's why these healthcare proxies are so important. They really are. Please, that's something that needs to be pursued. Every patient should have a healthcare proxy.
You know, I have to tell you, Ruth, my daughter has been after me for years to write a what my wishes would be. I've said this many times during COVID. So my specialty, I've said it many times right before we come to the end of the show, my specialty was working with people who were ventilator dependent and had trachs and respiratory conditions. And during COVID, she texted me one day and she said, so I have a question for you. If you had to go on a ventilator, what would you say? I said, no. She said, I thought you'd say that. She said, but what if it was for a short period of time? And I said, well, that's a discussion. Well, that was years ago and we still haven't had that discussion. I haven't written out anything and I really need to write out advanced directives. I'm 72, although people should really have it over the age of 18, in my opinion. And I haven't decided. She would be my healthcare proxy. She's my daughter, but it really should be stipulated because I don't have anything written.
Well, it's not only about intubation, it's about fluids. Do you want fluids provided when you're end of life? Do you want a feeding tube inserted? There are very specific items that need to be addressed. And I unfortunately have had some experience with this. I'm up there in age. And I had that with my husband, who developed COVID after getting all the shots, etc. And I said, I do not want him intubated because I have not seen an 89-year-old patient survive after they removed this,
we could have a discussion about that, I have to say, because I always tell people I've seen miracles and then I've seen the opposite. But before we go on, and we have to end in a minute, Teresa says, how do you handle situations where a patient is experiencing emotional distress or is not cooperating with the treatment plan? This is very difficult. These are very difficult conversations to have with a family member. I'm interested in what you would say. I personally have advised families sometimes to have an outside person, whether it's a doctor, whether it's a spiritual person, whether it's another professional, a family friend, who can maybe have some kind of discussion about,
I like the behavioral health nurses. They're excellent. Okay. And they're an outside person, and they go in and maybe speak with the patient when the family is not present. They're excellent. And I have gone that route.
Oh, okay.
And I just, it is very difficult.
Right.
There is one thing that I'd like to say, and that is that, unfortunately, if the patient is non-compliant, then the payer source has the right to say, I'm not going to cover that patient.
Right. That's true. Well, Ruth, this has been fantastic. I think we may need to have you come back again, because there's so much more to explore. And I think that, people are really thirsty for this information. And, it's invaluable. It's just absolutely invaluable to hear you talk about all of this. So I have to thank you so much for joining me on the program.
Really, I have so much information to, give. I really haven't had the chance to talk about the alternative to home care and what needs to be looked into before you make that decision. So,
well, we'll definitely have to have you come back and talk about that, because I know we got a little bit of a few minutes late start because of some technical issues. So we'll definitely have to have you come back and
I
talk
apologize
about that
for that. I'm sorry about that.
No, listen, it happens. But, I mean, people are very well aware there are technical issues that happen and crop up all the time. I'm sure everybody is well aware that has happened to them, and they've experienced it both as part of the problem, part of the situation, as well as on the receiving end. So thanks so much. I really appreciate you.
Okay, thank you for having me. I appreciate it. Thank you.
It was a pleasure. Please join me next Wednesday, June 18th at 7 p.m. Eastern Time for Senior Nation, when Debbie Levinson joins me for a conversation on resilience in aging, which is about a strength-based approach to growing older, a powerful exploration of the human spirit's ability to adapt, endure, and thrive across the later stages of life. Rather than viewing aging through a lens of decline, resilience in aging highlights inner strength, wisdom, and lived experience that empowers older adults to face challenges, whether physical, emotional, or social, with dignity and with determination. So remember to tune in, comment, and ask questions on June 18th at 7 p.m. Eastern Time on the Source TV Radio Network. And until then, take care, stay well, and stay tuned.
Go for it, go for it. I'm just saying I'm not finished yet. Search for it, swing for it. Discover the me that lives in yes. Stand for it, stretch for it. It's my time, imagine my best. Run for it, reach for it. Uncover the me that lives in yes. I know, yes I know.